All right. Hi, everyone. My name is Clarissa Domingo Javier, and I am a DNP F&P candidate and a registered nurse on a surgical step-down unit in San Diego. Today, I'll be presenting my quality improvement project that I've had the pleasure of developing and implementing during this program titled Improving Clinical Competence and Coping with Patient Aggression Through Live Instruction. Workplace violence is defined by the Occupational Safety and Health Administration as any act or threat of physical violence, harassment, intimidation, or other threatening disruptive behavior that occurs at the worksite. Workplace violence is an extremely researched topic, as many of us who have worked at the bedside are very familiar with its prevalence. The American Nurses Association, Bureau of Labor Statistics, OSHA, and other research projects have reported that 73% of all workplace violence-related injuries across all industries occur in the healthcare setting, with 1 in 5 healthcare professionals falling victim to these violent events. Between 2011 and 2018, there's been an 86.2% increase in violence in the workplace. And while anyone at the workplace may assume the role of the perpetrator, it's reported that 80% of workplace violence injuries are directly caused by patients. In 2016, California adopted a bill that mandates all healthcare institutions to provide employees with annual workplace violence training to combat the rising numbers. In compliance with this bill, many hospital systems across California provide workplace violence training using online self-paced modules. Allowing the training to be accessible online and allowing employees to go at their own pace is extremely accommodating for those who work variable shifts and serves as an efficient way for employees to meet annual compliance requirements. However, self-paced online training does not produce the same psychomotor skills needed to manage patient aggression in real life. Managing patient aggression requires interpersonal skills developed through case discussion, simulation, practice, and most of all, experience. Healthcare workers may not develop these skills solely on theoretical learning, which is why I chose to implement this project. Similar to the way in which the American Heart Association facilitates mega codes to improve learners' confidence and ability to spring into action, I feel that workplace violence training should incorporate a more involved form of training to produce a similar effect. The aim of this project was to answer the following PICO question. And bedside clinical staff with prior self-paced workplace violence training, could implementation of a live interactive workplace violence course improve staff confidence in coping with patient aggression? This quality improvement project was implemented at a Southern California Level 1 trauma center that serves the underprivileged and homeless population, with 2 sister campuses located in a more affluent area of town. Though part of a large hospital system, I chose to implement this project in an area with a higher risk for patient violence due to the patient demographics. Like most other hospital systems in the area, this hospital system delivers workplace violence training via online modules. And these modules comprehensively reviewed the definition of workplace violence and the hospital's protocols and resources, such as involving security and violent events. The inclusion criteria for participants are as follows. Participants must have completed self-paced online modules within the last year and must primarily worked in direct patient care. I offered 1 CEU credit as an incentive for participation and got 28 participants to attend the course. In preparation for project development, I reviewed the number of workplace violence-related incident reports submitted from all hospital campuses within this health system. I found that 68.6% of these incident reports originated from my side of implementation. And though this is not surprising given the demographics, I feel that this distribution of incident reports was disproportionate to the numbers produced by the site's sister campuses. I also polled the clinical staff on a neurosurgical progressive care unit prior to project implementation to get a feel for how often they personally handle patient violence without security involvement. I got 32 responses, and an alarming 72% of staff members dealt with patient violence without security involvement at least once per week. Many also verbalized that they do not often use other available resources after the event. Self-efficacy reflects confidence in the ability to exert control over one's behavior and social environment. and a stronger sense of confidence is supported by a solid base of knowledge of effective protocols and a mastery of skills. After reviewing the poll and the workplace violence incident report statistics, I was even more motivated to provide staff members with a more comprehensive training course that included a live interactive component to ultimately improve these numbers. This training course was titled Live Workplace Violence Training, and it was delivered using PowerPoint and Zoom presentation tools. The program's objectives aim to get participants to develop a strong sense of confidence by understanding the facility's protocols and resources and solidifying de-escalation techniques. The course reviewed the following 5 items: the definition of workplace violence, interfacility statistical data, such as activation of security services versus incident reports submitted versus the actual events, the healthcare facility's workplace violence management policies and staff resources, useful tools to recognize escalating patient aggression or violence, and de-escalation techniques recommended by the Joint Commission. The course content may be viewed using the QR code at the top of this poster. So prior to my course presentation, participants were asked to submit a pre-intervention self-assessment survey and a post-intervention self-assessment survey. Both were to be completed and submitted within 10 minutes to the start of the course and within 10 minutes after completion of the course. The contents of the survey included questions from Dr. Michael Thackeray's validated therapeutics for aggression self-assessment tool developed in 1987, which may also be found using QR code. Other questions on the survey pulled questions directly from the hospital's workplace violence prevention policy as well. Though the aforementioned information may be found in the self-paced learning modules, my program incorporated 3 video case studies that participants were asked to dissect and discuss with the instructor and their peers. The first video exemplified an extreme example of violence in the workplace and an inappropriate response by the healthcare workers in the video. The second video was another what not to do case study embedded with a patient aggression recognition tool within the video. This was the BARS tool, which may be found using the QR code. The third and final video in this presentation showed proper de-escalation techniques. And immediately after showing each video, I asked participants to discuss what the healthcare workers in the video did correctly, what they could have done better, and to discuss what they would have personally done in these situations. Following each video discussion, I reviewed the Joint Commission's de-escalation technique recommendations and facilitated a 5-minute open forum to debrief. The course provided participants with the tools to approach patient violence more confidently. In comparing pre- and post-intervention surveys, participants increased their self-confidence scores by 15%, implying that their perception of self-efficacy had improved immediately after receiving the course content. In the weeks and months following project implementation, I sent out 2 additional follow-up surveys, one at 4 weeks post-implementation and one at 5 months post-implementation. The survey sent out at the 4-week mark asked participants to indicate whether or not they have used clinical aggression assessment tools such as the BARS or STAMP tools in practice. The follow-up survey showed that nearly 70% of participants have used the BARS tools, STAMP tool, or other aggression tools in practice, as depicted in the bar graph at the center of this poster here. The 5-month follow-up survey asked participants to indicate their success rate in de-escalating patient aggression since attending the course. This survey showed that nearly 67% of participants report being mostly or always successful in de-escalating patient aggression since attending the course, which is also depicted in the pie graph at the center of this poster. Though participants were already trained to deal with violence in the workplace through the online self-paced modules, the results suggested that learning theoretical approaches independently simply isn't enough to develop the interpersonal skills needed to cope with patient aggression or empower self-efficacy. So to answer my PICO question, yes, live interactive workplace violence training does in fact, oh no, my poster. Sorry about that.
No worries, you can just put it back up.
Let me pull it up. And sorry about that, guys. Are you able to see my poster again?
Yes, go ahead.
Okay. So as I was saying, yes, live interactive workplace violence training does further improve clinical staff confidence in coping with patient aggression. So limitations and challenges. As with anyone implementing a practice change project, I did come across some challenges that limited my project from reaching its full potential. I initially wanted to implement this project in person so that participants could physically practice. However, social distancing requirements limited my options for implementation. Thankfully, we've got applications like Zoom that made it possible to still implement the project and produce a similar effect. In implementing this project, I found that this type of intervention proved to be clinically significant and worth exploring further. However, other scholars may challenge the validity of my project's results due to my small sample size and single practice implementation. Lastly, getting participants to complete the follow-up surveys was a bit of a challenge as well. Even though the post-implementation follow-up surveys took less than a minute to complete, many participants were unable to submit the surveys because they were either busy at work or were just unavailable to respond at the time that I sent the survey out. If I were able to implement this project again, there would be a few things that I would change to help strengthen its validity. I would, one, reach out to a larger group of potential participants, and I would also advocate to implement this intervention in person, as originally intended. The great thing about this project, though, is that my project protocol allows for easy replication on either Zoom or in-person platforms, as long as it continues to incorporate a live interactive component. Overall, I feel that my project was successful in supporting the need for interactive workplace violence training. And as the nursing community continues to explore the best ways in which healthcare institutions may create a safer environment for ourselves and our colleagues, I hope that my project may contribute to this cause. But before I finish up here, I'd like to thank my DNP chair, Dr. Wyckoff, for her guidance in developing and implementing this project, Dr. Michael Thackeray for allowing me to utilize his validated survey, the clinical staff members and members of management on the neurosurgical progressive care unit for their constant encouragement. And finally, my family, friends, and loving husband for their unwavering support and reassurance during this entire experience. You guys have all been so wonderful, and I wouldn't be here today without you all. So thank you so much for listening. Sorry for the little hiccup, but I now open the floor for questions.
Thank you, Clarissa. That was an excellent presentation. And I appreciate everything that you have done to bring this into fruition and to facilitate addressing some of these difficult issues. I'd like to open for Dr. Rush to go ahead and ask your question.
Yes. First of all, Clarissa, great presentation. Really important work here. Several years back, when I was vice president of the Wisconsin Hospital Association, I was approached by a group of nurse leaders in the state of Wisconsin to see if we would, as a hospital association, be interested in taking this project on as one of our 10 to 12. We always listed 10 to 12 key projects per year in our planning. And I was, of course, on board right away, being a nurse, having experienced this myself, working in the ER. But I met a lot of resistance from physicians, believe it or not, that said, this is just kind of part of your work job, part of your work, part of your everyday work. This is, what do you expect? Patients are in pain. They're this, that. Almost as like we should say violence against nurses in the workplace is part of your everyday experience. And I'm just wondering if you have ever experienced that pushback or that resistance, not just from physicians, but nurses or others in healthcare.
Thankfully, I've been a part of really great teams in my entire nursing career that, we have a really really strong sense of camaraderie between all of us. And, I've always worked in teaching hospitals, so people are actually pretty open to figuring out ways to make our workplace a lot safer. So what was really great about my project, or going through my project, was I had great support from my management, as well as my colleagues at work. And we also have this symposium that my hospital does every year that advocates for new projects. So the openness of my site and of all the units that I've ever worked on, I didn't really meet too much resistance in doing that, especially since the majority of my colleagues, were right there. We're experiencing, violence against us, and knowing that 80% of violent events happen because of patients, or not being able to recognize those early signs. It made my project well received amongst my colleagues.
Great, thank you so much. And again, thanks for doing this work. It's really important.
Dr. Hollis?
Yes, well, Clarissa, I really thought that this was great. I really got a lot out of it. And I must say that I could see this being part of even staff orientation. This could be part of a training program when we bring staff in from the very beginning, so that they know that they are supported, they know that they're being given those tools. So in terms of next steps, I mean, that could absolutely, because you want it to be in an in-person setting, I could see that being added to, the orientation program for an organization. So this is really important. It's so important for everyone to feel safe. And I enjoyed your presentation, and I wish you the best in next steps for it.
Thank you. I initially wanted to implement this project with new grads, actually, because they're at the very start of their nursing careers. I really wanted them to get a really good base of information as they're developing their nursing skills. And unfortunately, because the new grad programs are so dense with information, I wasn't able to do it amongst new grads. I did also want to try to do it with staff members who had only been at our facility for less than a year, just so we can really catch it early. But because the orientation programs and whatnot are really dense, like I mentioned, I had to kind of expand it to just the entire unit, rather than just the new orientees. But thank you so much.
Of course. I mean, it's a work in progress. I mean, continuing on. It's okay if you weren't able to do it at this point or that point. It's a whole process. So well done. Well done.
Thank you both, Clarissa and Dr. Hollis. And anyone else with additional questions for Clarissa? Clarissa, I would just ask you to share, you started to touch on it a little bit, regarding your facility support with respect to the evidence-based interventions that they do seek from their nurses, and how this was able to facilitate and support you and your project.
Yeah, so I actually was a part of my hospital is they do this thing called EBPI, which is Evidence-Based Practice Institute. And every year they have a symposium that all the hospitals in San Diego, or a lot of the hospitals in San Diego, participate in. And it's essentially a 9-month program where they basically hold your hand through the whole process of developing an evidence-based practice change project. So I had a lot of support coming. I'm very, very fortunate to have a lot of support from just that institution alone, the EBPI. And on top of that, my management was amazing and very, very supportive. So my management and the EBPI directors were in communication with each other the whole step of the way, and I was able to, ask them questions and really ask them to help me develop my my idea for how we can get the ball rolling with my project, and it helped greatly in developing it for my DNP program. So they helped me get IRB exemption. They walked me through the whole process, and it really helped with all the behind the scenes stuff to make it nice and pretty and packaged for our presentation today.
And I would personally like to thank some of the individuals who are on this call from your facility because they worked so closely with you, and in turn was very supportive of our actual DNP program and was well aligned with exactly the same goals. Their facilitation certainly helped you with data collection and support in implementation. And as Samuel Merritt faculty, I would like to personally thank them for this, because one of our biggest problems, especially during COVID, has been project completion. So very excited we were able to bring this program to your facility and to actually implement it and help you to complete your project.
Yes, I actually do see them on the chat or on the participant list. So I just want to say thank you, Diana, Heather, and Josh for being very, very supportive and for tuning in. I appreciate you guys so much.
Thank you. Do we have any other questions or comments from anyone that is on the call? No, I see a lot of people smiling, so I want to thank you so much. And if you have any family members on here, I want to thank them so much for joining and thank them for your support during this time. And thank you for bringing such a wonderful individual to our facility and to being able to attend our program. And congratulations, Clarissa, very well done.
Thank you. Thank you.